Oration. Dr. C.G. Pradhan Oration is started from this year only, and this is the first oration given by Dr. Mandeep Dhillon, and the topic is looking to the future, how will fracture care evolve. Professor Dr. Mandeep Dhillon is a professor and head of Department of Orthopedics, Physical Medicine and Rehabilitation, head of Sports Injuries and Clinic at PGIMR Chandigarh, India. Slides. President of many national societies like Indian Orthopedic Association, Indian Biologics Orthopedic Society, Indian Arthroplasty Association, Indian Association of Sports Medicine, Indian Foot and Ankle Society, North Zone Indian Orthopedic Association. He has a special interest in arthroscopy, lower limb arthroplasty, foot and ankle trauma and sports medicine. He has written many books. He is editor of IOA Manual of Foot and Ankle Trauma. He has more than 400 publications to his name. The future of practice, the topic is future of practice, how we go ahead. And he is a very jindadil person. He is a very active and dynamic, and with a proud and privilege, I introduce Dr. Mandeep Dhillon for the oration. Before that, I request our president to felicitate him with a traditional pagdi. And
I would just like to say one thing about our dynamic president. He is one of the few Indian president of the IOA who has a multifaceted personality. He is a good academician, he is a good clinician, he is a good surgeon, he is a good researcher, and most importantly, he is a very good family man. So big round of applause for our most dynamic president of IOA.
Thank you, Parag. Me पण मराठी आहे. Thank you, Pune. Thank you, Maharashtra. Thank you, Parag. My seniors in the audience, I have such respected teachers, my friends in the audience, my colleagues, some of my students over here, ladies and gentlemen. It's been an honor today to look into the future. I've been asked to look into the future and give a talk which is the late Dr. Pradhan Oration. Dr. C.G. Pradhan completed his MS General Surgery from Nair Hospital. He joined Dr. K.T. Dholakia as one of his earliest associates in Bombay Hospital. He also served KEM Hospital as assistant honorary and later became the professor and unit chief. Though he was a strict man, serious during his teaching, and kept to all his training commitments, he was a very kind-hearted person and a warm human being. One of the big things about him at that time was his interest in PG teaching. He taught the residents of KEM Hospital and Bombay Hospital with zeal and fervor which you perhaps cannot see today. His academic and surgical focus of what he was famous for was for the management of stiff elbows, where he followed Dr. Bhattacharya's elbow arthrolysis, and he did many of these in Mumbai at that time. I'm going to end by paraphrasing Ralph Waldo Emerson. The purpose of life is not to be happy. It is to be useful, to be honorable, to be compassionate, to have it make some difference that you have lived and lived well. This, ladies and gentlemen, paraphrases the life of Dr. C.G. Pradhan. I will now move on to the talk at hand. I have been asked to look into the future. There are so many things which are important about the futures, but we have to take all of this in perspective. If you look at things over time, that's us today. but we also have to look into the past to learn what went before us so that we can apply all of this to be able to improve the future. Now, this idea of what should we think about the future is not ours alone. 2015, I went to Dubai. I was invited as faculty to the Pan-Arab Orthopedic meeting, and they had a separate pavilion, which they called the Future of Surgery Zone. I went in, I looked around, and truly, I was amazed to see what lies in store for us. The things which we take for granted, like lasers, endoscopic, transplant surgery, all of them would be so evolved in subsequent years that this is amazing for us all to see. One little thing we now realize, that we as doctors, as surgeons, have evolved a lot. It's taken us about 5,000 years to reach what we are today. And all this which we learned in 5,000 years will change in the next 20 years. The learning accumulated over 5,000 years would be the same as the next 20 years. And therefore the question which we ask is, what will happen to fracture care? Will it change? Will it evolve? Will it be recognizable? So again, as I said, let's start with the past. 25 years ago, the future was looking to understand how fractures heal. We were looking at trying to understand the biology. Today in 2018, the future is looking at changing the biology to stimulating fractures to heal. And to understand and do this, we've already got the research needs identified. And these involve three things. What would be the diagnostic for trauma in the future? What would be the therapeutics for trauma in the futures? And what would be the interventions for trauma in the future? Let's start with the first one. What is going to be diagnostic trauma interventions in the future? Today, we look at fracture repair through X-rays. We see calluses forming, bone is healing, but slowly things are moving. We are trying to look at dual X-ray, absorptiometry, CT, etc., which may give you quantitative info about the callus which is forming, which will give you the orientation of the callus which is forming. Is it forming on the good side or the bad side? So rather than just saying callus is forming, in the future, you are going to be quantifying bone healing. To add to that, let's see whether MRI would help us in fracture assessments. Well, things like diffusion, MRI, etc., will tell you the physiology of that callus. Will tell you whether that bone is living bone or dead bone. And even whole body MRIs are coming into the play, where you can look at polytrauma patterns, etc., etc. And the exposure is similar to PET and CT scan, and it's much, much familiar. But the future actually would be hybrid machines, which would be a combination of MRI, PET scan with less exposure and superior accuracy. For example, today, even nowadays, the holomer is in existence. This does a total body scan for a total diagnosis. So if you get a patient with polytrauma and head injury and he comes to you like this, you could get an evaluation of his whole body, his organs, his head, his skull, everything. And nowadays they are using this in some centers to do even a virtual autopsy. You don't have to cut up the patient, you can do this, and then you can sort of have your statistics from your autopsy. So gentlemen, in 2030, you may not be looking at X-rays, but you may be actually doing only virtual imaging. Now what about management of these cases? Are we going to be managing it the same way, the same levels of intervention? Well, this is going to change, let me tell you. One of the big things in the underdeveloped world today is patient transport. This is how patients are transported in India. But the world does not accept that. What is the world coming to and what it will evolve to is something called the life support for trauma and transport. LStat. It is called an LStat, which is something like a glorified stretcher, which has everything: a defibrillator, a ventilator, suction, monitoring, oxygen, batteries, Wi-Fi connectivity, does a blood test for you, sends it to the hospital in advance so they are ready for you whether your oxygen is low, etc., etc. This is not futuristic. This was used by the US Army in 2000 in Kosovo, and it is an established military practice for them. This can even be wheeled into the OT, and the surgery can be done the same thing with the patient like that. But this is present day. What about the future? In the future, you will get LSTAT light. That means the machine could become smaller. It could become a backpack version. You could attach it to a drone. Get your patient stabilized. His real-time monitoring is being done. Putting on a drone, the drone will remotely take him to a hospital where on the way his oxygenation, everything is being done. So patient transport in trauma is something which is significantly evolved. So in the future, folks, trauma transport may be in a backpack, not in a back lift. What next? Don't stop believing, because the fracture treatment in the future would be something like an assembly line. Age-old problem in fracture healing. Always in the past, today, we are trying to enhance union. And we do it by two methods: internal stimulation in some way and external stimulation in some way. So let's look at what are the external stimulants which are in vogue today. Mechanical stimulation, weight bearing, electrical stimulation. All of this have a lot of ongoing research at the current moment. One little thing, low intensity ultrasound came in with a big bang in the 1990s, but its focus is now only on some specific fractures like the scaphoid, the tibia, maybe the distal radius. Big thing was, these machines were big. They did not give you enough data to be able to recommend them. But now, and in the future, these machines are becoming smaller, and they are being combined with medical therapy like teriparatide or other stimulants, etc. And this is becoming much, much more focused. Even the plaster casts which you are applying are changing. Now you can get computer-generated plasters printed out in a 3D model with holes in them so that they don't have to scratch during the monsoons and they don't have problems like that, and exactly identify the area which needs stimulation. And you can add this little bit, this ultrasound monitoring, give the drugs, give the immobilization, and take it forward. This is coming in the next 5-7 years. In India, Weber, Bagaria and all have been writing about it in the journals for some period of time. What next can we discuss about the future of trauma care? Well, this is about pre-intervention. What is changing could be how we intervene surgically. In the 21st century, please note, robotic and mechanical devices will significantly assist us. I like that talk by the anesthetist who talked about robotic endotracheal intubation. Those are small things. 20 years ago, the future for fracture care was minimally invasive surgery. When they started doing this without opening it, it was thought to be very, very futuristic. We are doing it routinely today. And similarly, the future for fracture care could be computer-navigated fracture fixation. Like you do. For TKR, computer navigation is accepted. It gives, if not better results, I don't say it gives better results, equivalent results to humans. So if you use it into trauma, it may evolve to replace the C-arm totally. And look at the radiation we are saving. So you could have computer-navigated fixations of fractures without the radiation. What about you? What about the surgeon? Are you going to be the same? I'm not so sure. Because look at all the sci-fi movies which have coming out to be true. The surgeon is definitely going to be looking different. The OT is definitely going to be looking different. You're going to be getting robotic arms, user interfaces. That pretty nurse you always kept to assist you is probably going to be replaced by this ugly robot. And I'm not so sure if in the near future we don't see operating rooms like this. Gentlemen, it takes a little time for us to accept things. I do not know whether you know which age we are living in, but some people have called it the biointelligence age, which is one step further than the technology age. So if you look at the history, like I said, we started with the agricultural age. It took us so long for it to be accepted by the people. Then came the industrial age. Took slightly lesser time for it to be accepted by the people. The technology or information age came that much faster. And the biointelligence age, still not accepted, but going at the fastest speed possible. Over here, it's a combination of biological, physical, information technology, which will transform into something good for the future. Let's come back to today. Let's look at actual bone healing today and bone healing in the future. Nowadays, most of us have a lot of interest in internally stimulating bones. How do we do that? We have this age-old autograft. Stood the test of time, it's a gold standard, and these are 5 or 6 or 4 properties which are a must. But in the future, you're not going to digging out their iliac crests or their proximal tibias. We already have a huge list of things which are available for us. And there's possibly going to come a time when we could add cells to this and not have to trouble anybody's iliac crests. In the US, ceramic-based substitutes are already 60% of the use. I do not know what's going to happen in 5 years, 10 years today. But I think in a different way. Why do we need to add grafts? Why can we just not get that damn bone to heal itself better? Can we do something there instead of putting in grafts? And that's where the field of so-called, a new term called orthobiologics has come into being. And this is not new to India. We formed the Indian Orthobiologics Society in 2014. And let me tell you, people are actually thinking that this may be the next final frontier. That we could do things, we could use enzymes, we could change the internal environment of the bone to stimulate osteoblasts to do the job they are designed to do. Marshall Urist thought about it 30, 40 years ago. He looked at BMP because it was identified that BMP is the thing which gets bones to heal. So they made recombinant human BMP, but there were some problems over there. It was thought to be a wonder drug, but, and if you look at it even today, there are thousands and thousands of publications trying to look at it because one, it's too expensive, it's not cost effective, and it definitely needs improvement because there is a downside to BMP. There are significant adverse effects. It has the potential for carcinogenesis, and the FDA has only allowed it for use in the cervical spine and in the tibia. So therefore, naturally, the future of bone healing is taking a different path. There's an obstruction there. They've gone into different path. They're exploring different orthobiological properties. One of them is my favorite subject, which is platelet-rich plasma, because the platelets have so many signaling molecules inside them which act at different stages of the healing cascade. And once we know more about it, we don't know enough today, once we know more about it, we could understand which stage of the healing has the problem and give that exact molecule at that right time and perhaps help the fracture to heal. And we've written about it in the Indian Journal of Orthopedics. And let me tell you folks, although I do not have conclusive proof, PRP could become the building blocks of the future. Why only PRP? We have significant cellular elements over here, the stem cells. And their importance is not sort of foretold by you and me. It is foretold by the money makers, the businessmen, the bankers. They are the ones that know that things are going to work. So the amount of money which is going into the stem cell industry is huge. So don't think like an orthopedic surgeon. There is something there. Because everybody knows the basic things. There's this good cell inside our body which wants to unite. It's there everywhere. Every organ has it. And if we could get it to come and form bone, we are a winner. As of today, bone marrow is the commonest source of stem cells. We take it from the iliacras, but we have some problems. Although it's cheap and easy, there's a downside. The stem cells are a very small fraction of it. And you can't take it from osteoporotic bones, elderly patients, etc. So what we are changing now, what the future will be, is where do we take the stem cells from? And more people are forgetting about the bone marrow and are taking it from the fat. And the next big heavyweight fight is going to be the fat cell versus the bone marrow stem cell. And the fat cell is winning because the Time magazine and everything else is looking at this being one of the greatest inventions of the last decade. And in the future, this may be the stem cell to work on as we go. But not only the stem, there are other issues also. Techniques of extracting these, techniques of concentrating these cells are evolving. And rather than just putting them into a petri dish and cultivating them, we've got so many other things going on. Today morning, one of the breakfast sessions was on autologous osteochondral transplant, or osteoblast transplant, which I worked on also. And you can culture these osteoblasts, put them in the right place, and work with them. But the most important thing you have to understand, the future may not be one thing alone. The future may be a combination of therapies. You know what is the best from A, B, and M. Use them appropriately. Use things like these surgical consoles and apply them where it is needed. Understand which stage of the fracture healing is a problem, and it's only then that the hype will be translated into reality. I cannot leave this stage without thinking of other things. We all have genes in us. And there's a lot of interest coming in about gene therapy for bone regeneration. Everybody's got genes which have got some part of it which stimulates your bone to heal. Can we not go down to that level? Manipulate your genes to produce more BMP. And this is not something futuristic, it's being done today. Some of this genetic material is put into carriers, could be a virus, could be a stem cell, and then put at the target cell. So this is being done, this is because it's better than giving a single shot of a high dose of BMP. And these genetic altered cells can go on working for a period of time to produce more and more bones. So actually speaking, there are two methods we currently know about how to do it. First method is take out the stem cells, get them multiplied outside, put in the therapeutic gene, re-implant it. Second method is you directly apply the gene to the site where you want the bone to heal, and those cells will take it up and act as the carrier. So this is something which is probably going to become more refined. But even more than that, combinations may be even better. You could put in a scaffold, put in stem cells with modified genes, put in maybe PRP, etc., and you could get that much better bone healing. Remember, whatever I have talked about, you can use, or we would probably use, anything as a combination over here. All trauma does not end with bone healing. Crushing, polytrauma, amputations are a problem. So we cannot leave talking about trauma care without looking at what is the future of rehabilitation. We now have bionic limbs. We have what we call as intelligent prosthesis, which can work. And there are soldiers in Iraq today, about, if I'm not wrong, about 740 of them who have gone back after amputations, joined their units because they have these intelligent prostheses. And they will improve over time. And they will let you do what you did with your with your original arm or leg. Folks, technologies will change the future. They will change you. They will change your patient. And this leads us to a moral dilemma. Is it good or is it bad? Remember, technology is neutral. It is us who have to breathe in the moral and ethical life into these technologies. Then we have to apply them with empathy and compassion for each case. And when we look at, when I was asked about so many of these speculations about the future, there's so many thoughts. Somebody says it will be great. Somebody says the future is going to be awful. But the one single fact which is important, the future doesn't care what you think. It's going to come there regardless. And that is why we have to be aware, we have to be proactive, and we have to let us see where the future takes us. But I'm going to end with one simple fact. It is not the futures which will take us somewhere, but the fact is the future is ours to create. Thank you for your time.